So good afternoon, everyone. We're excited to welcome you all to another inspirational and educational episode of Concorde Conversations. Concorde Conversations is an initiative by Concorde Medical Group to encourage our community about their health so we can all live to our fullest potential. Today's episode is all you need to know, a discussion about knee pain. Hi, I'm Dr. Catherine Weinberg, Director of the Adult Congenital Heart Disease Program here at Concorde Medical Group, part of Northwell Health. And today we are joined by our outstanding orthopedic sports medicine colleagues from Lenox Hill, Northwell Health Physician Partners. I would like to introduce you all to the amazing Dr. William Schell and Dr. Michael Zacchilli. Both are athletes and both are board certified physicians. We had a great response from our Concorde community about our webinar today, and many of you have submitted amazing questions, which we will ask our experts. If you have any additional questions, please ask them in the chat box. We only have 30 minutes together, so we're going to go through as many as we can. Remember, we're giving general guidance. If you have a particular question about your health, we want to help you. Come in and talk to one of our exceptional Northwell physicians so we can answer your questions and give your health the attention it deserves. So let's get started. Dr. Zacchilli, Dr. Schell, both of you are amazing athletes. What sports do you play? And how does being an athlete affect how you practice medicine?
So I grew up, I was a 3-sport athlete, soccer, wrestling, and volleyball in high school, and played both rugby and volleyball in college. And so, my general approach as a sports medicine doctor, I was an oft injured athlete. And so that's really important to me to try to keep people on the field. I think when we're dealing with sports medicine injuries, the fear a lot of patients have is that they're going to come and see us and we're going to shut them down or tell them they can't do things. And my approach really is to try to help people to get back on the field and to try to facilitate that as much as possible. Really taking it from the athlete's perspective and not the policeman who's shutting them down.
Okay, what about you, Dr. Schell?
I was a swimmer. I swam basically, all through college and beyond. I was part of the U.S. national team. So I've seen many of my colleagues and myself be injured, have to be out temporarily. And, when you're a high-level athlete or even just a weekend warrior, you want to be active. So from my standpoint, it's good to have that background of having been there injured and not being able to play and just waiting to get back in the game. So it does give that perspective from an orthopedic standpoint.
Great. So let's start with some questions. Dr. Zacchilli, what are the most common causes of knee pain?
Sure. I think the most common issues we see with knee pain really fall largely into 3 or 4 categories. The most common one probably is arthritis. And that's something we see in our older patients in particular. Then we see soft tissue injuries, muscles, tendons, things of that nature, strains and sprains. And then the last category is really more structural, what I think of as structural injuries. So things like ligament and meniscus injuries or cartilage injuries. And I think that probably those are the 3 major categories.
Dr. Schell, what are red flags? When should a patient go to the hospital immediately for attention? And when can you wait to see the orthopedist?
The general red flags are when the pain is just inordinate, where the pain is so severe that you can't even put weight on it. If it's a new acute injury, we're more concerned for a fracture, and that's something you probably don't want to wait too long for. If you've had prior knee issues, let's say from arthritis and some pain and it flares up, if you already know that, you don't necessarily have to run off to the emergency room if it's consistent with the past, but really inability to walk and more in a traumatic setting.
Dr. Zacchilli, let's talk a little bit about the anatomy of the knee. Can you tell us what an ACL is, what an MCL is? What's a meniscus?
Sure. So the ligaments, there are 4 major ligaments in the knee. The MCL or medial collateral ligament and the LCL lateral collateral ligament are on the inner and outer edge, and they kind of act like a hinge in the knee. They kind of keep the general hinge bending and extending position set up. And then inside the knee, we have the cruciate ligaments. They're called the cruciate ligaments because they cross like an X. So the anterior cruciate ligament is the one in the front. That's the one we hear about the most. And that ligament prevents the knee from rotating and also for the shin bone from slipping forward underneath the thigh bone. And so those ligaments really play a role in keeping the bones centered and positioned relative to each other for normal movement. The meniscus is a slightly different structure. Meniscus is cartilage It's a different cartilage than we think of when we think of the cartilage like with arthritis. Cartilage in the knee, when it comes to meniscus, is like a rubbery shock absorption type of cartilage. So we have a meniscus on the inside and the outside part of the knee. So there are two meniscuses in each knee. And those really help to absorb force from impact. They also play a secondary role in stabilization and kind of support some of the ligaments.
Dr. Schell, what are the symptoms of a ligament tear, an ACL tear or an MCL tear?
So we'll start off with the ACL, which is common, although an MCL is common as well. The most often it's a non-contact injury where someone is moving around and they'll basically feel a click or pain in the knee. It can swell, and as the swelling goes down, a lot of times the patient will feel instability, even just general activities, twisting and turning. They feel like the knee's buckling on them. An MCL tends to be more of an injury where you get hit from the outside part of the knee and it pushes your knee towards the other knee. That tends to be swelling, but also more an exquisite pain that just is not going away.
Okay, Dr. Zacchilli, do all ACL tears require surgery? What about an MCL? Can you discuss a little bit about the different types of surgeries?
Sure. So, the MCL, luckily, it's probably the most frequently injured ligament in the knee. Most of those are mild, and in most cases, we can treat that with just some rest. So when we talk about a knee sprain, an MCL is a very common knee sprain. An ACL is a little bit different. ACL is a pretty important ligament in the knee, and if you don't have one, then certain movements can be difficult. So in particular, pivoting or sudden changes in direction. So, as to whether or not that needs a surgery, it depends a lot on your activity level. It depends on your desired types of activities. So, someone who's running in a straight line all the time, oftentimes that's somebody who can tolerate missing an ACL better. But someone who's a soccer player, basketball player, pivoting and cutting sports, those patients are much less likely to tolerate not having an ACL. And then I think, age is a relative consideration. We know that if you don't have an ACL that's functioning, your long-term risk for arthritis is higher. That has a much bigger impact on an 18-year-old than it does on a 40 or 50-year-old who might already have some mild arthritis. So in terms of restoring the ligaments to protect the knee, we care about that more in our younger patient population. That being said, that stability, especially with the pivoting and cutting, plays a role throughout the entire activity timeline, the entire age group. And so an active older patient is going to need that surgery just as often as an active younger patient.
Okay, Dr. Schell, what's recovery of an ACL surgery?
So I generally tell patients it really comes down into two categories: the acute recovery from having the surgery, and then more the when am I back to sports? When can I get back and my knee is my knee again? Thankfully, with techniques nowadays, recovery is pretty quick. It's an outpatient procedure. All right, you come in, go home the same day. Most patients will be using either crutches or a weight-bearing assist for the first week, sometimes a brace for about a week and a half. But most patients pretty quickly feel better. Within sort of days, they're starting to feel better to the point at 2 weeks from surgery, you're walking around, you're already on a stationary bike, doing therapy, walking, but not running up and down the stairs necessarily. We really hold people off, though, to full activity, meaning high-end sports, at a bare minimum, 6 months. Most patients, we tell to wait about 7 or 8 months, really just to build your strength up. But it's really not PT for even that long. Most patients will go to PT for 2 or 3 months and then kind of do their home exercises on their own. We're just really waiting for the strength of the muscle to come back so you don't put yourself at risk again.
Okay, so let's talk about meniscus tears. Dr. Zacchilli, what are the symptoms of a meniscus tear?
Sure. So that meniscus tear, like we said, is a shock absorber in the knee. So one of the most common things we see in the setting of meniscus tear is the effects of that lack of shock absorption. So some patients will report that the knee feels not quite as cushioned, or it will feel unstable. We see reactions in the knee from not having that cushioning, so the knee can swell. We get fluid in the knee. And pain. Most typically, the meniscus on the inner aspect of the knee, that's the one that's most frequently torn. So some pain in that area is very common. The real distinguishing characteristic, at least when I think about meniscus tears in terms of how we treat it, depends a lot on whether we have what we call mechanical symptoms. So mechanical symptoms are when we have something that's actually physically getting caught or stuck in the knee, like rocks in an engine or something of that nature. So if your knee feels like it's getting stuck or locked or in a particular position and you have to manipulate it or move it to get it unstuck, And that's one of the more concerning and more specific kind of characteristics of meniscus injuries.
Okay, Dr. Schell, when do you need surgery for a meniscus tear? And what is the recovery time like?
Yeah, so as Dr. Zacchilli said, if you have mechanical symptoms, that pushes you more to having surgery. If you have underlying arthritis and you have meniscus tears, that's actually fairly common to have more of what we call a degenerative tear of the meniscus, and a lot of times that actually doesn't have to be fixed. So a lot of times patients will say, hand me an MRI and say, look, I have a meniscus tear, but when I look at it, it's really more maybe some arthritic concerns, and a lot of those we can actually avoid surgery. They can recover with therapy. If we do end up having required surgery, again, the surgery is very quick. You come in, go home the same day. The actual procedure is really 10, 15 minutes at most. It's very quick. Most patients are walking on it pretty quickly. You can elect to go to physical therapy. I tell my patients, honestly, only about a third after a simple meniscal surgery elect to go to PT. Most patients are back doing high-end sports anywhere from 3 to 4 months. I started 3 to 4 weeks. I apologize. So it's a very quick recovery from most meniscus tears.
Okay, so let's move on to arthritis. What exactly is arthritis, Dr. Zacchilli?
Right. So that's a really important concept. I think a lot of people think of arthritis as a like any other health condition, as a condition you get. And what I try to explain to people, arthritis is not something you get. Arthritis is the loss of something. So on the end of our bones, we have shiny white cartilage, just like on the end of chicken bones. And that's what helps to cushion our joint along with the meniscus. When you get arthritis, what that is the loss of that cartilage. So you lose the smooth cushion sensation in your knee. You get grinding, rubbing, achy pains. And so that's what arthritis is, the loss of that cartilage.
Okay, so what are the most common symptoms of arthritis, Dr. Schell?
So pain is by far the leading one. That generally is what brings people into the door, so to speak, to say, hey, it's painful. But not just that, it can be swelling. Swelling can be a big factor where patients are like, my knee hurts a little bit, but it's just so swollen, it's stiff, it's achy. It'll be in the back of the knee, the front, all bounce around. Patients will often complain of buckling or that their knees giving way. Although with arthritis, it's actually everything is clinically stable, but it's a pain reflex that when you have it, you feel like your knee's unsteady, and that alone can cause you to come seek treatment because it just doesn't. Your knee changed. It's no longer what you remember it being.
Okay, so when do you refer for a knee replacement? There's Zacchilli.
Yeah, that's a great question. I think I always try to tell my patients that they know. We get the question all the time, like, am I ready for a knee replacement? And I always bounce that back to my patients, like, you're going to know when you're ready. Now, what are some general guidelines? My usual rule is that when your knee is making more decisions about your day-to-day life than you are, then that's when you start considering it. So, rules of thumb: if you can't walk 1 or 2 city blocks without having to stop because the knee hurts, if you can't go up or down 1 flight of stairs because the knee hurts too badly or you're taking elevators, or if you're looking at your day and say you want to go somewhere and you think about your day and you say, you know what, I do want to go, but my knee's not going to allow that. I'm not doing this tomorrow. Then that's a starting point to discuss treatment options for it.
Yeah, and I would agree with Dr. Zacchilli in that regard. That I always tell patients the only time you ever need a knee replacement is when you come in and say, I need a knee replacement. There are things we can do to help make you feel better, but when the bad days far outnumber the good days, and your quality of life is, and patients come aware to it. They know when they're ready.
Okay, so let's speak a little bit about the recovery and how long do knee replacements last, Dr. Zacchilli?
Sure. So recovery for knee replacements, I think Dr. Schell and I also do shoulder replacements, and I'm sure people out there have friends who've had hip replacements. I think it's the hardest early recovery of any of the replacements. The first 3 months, you get a lot of stiffness, a lot of achiness, and it just takes a lot of time to get that motion back all the way to where you don't notice it on a day-to-day basis. That said, most people come in, they're already stiff and achy, so it's not a huge difference. I think 3 months is the first time most knee replacement patients feel different than when they first came in. And I tell most patients the first time you're going to feel really good, that you're going to be happy, really happy with your knee, is usually around the 6-month mark. Prior to that, it will feel better, but you're not going to be really thrilled just yet. And from a long-term standpoint, in terms of how long they can last and how they feel, I think a lot of that depends on what you expect out of it. And touching on our last question, one of the reasons we don't want to jump and do a knee replacement really early is that it is a mechanical knee. We're not replacing the knee you started with early in life, right? This is a knee made out of metal and plastic. And so it's not going to feel exactly normal. And so if you expect it to work for you for daily function, for going up and down stairs and walking, that's going to be great. If you're trying to get back to high level sports with a knee replacement, it's asking a little bit more of it. And I think there's oftentimes a misconception about how well it works in that situation. That can also affect how long it lasts. So someone who's trying to run on a knee replacement or play sports regularly on a knee replacement, they're not going to get as long out of it as someone who's just looking for what I call city miles. So if you're off-road miles, you're looking at, 10 to 15 years for a really young, active, larger patient. If you're looking for just city miles in our older patients, you can get 20, 25 years.
Okay, Dr. Schell, can you talk a little bit about physical therapy? Does that help with knee pain?
Yeah. So therapy is probably one of the most tried and true things. Obviously, we're orthopedic surgeons, but the vast majority of treatments that we do are non-operative, right? And so therapy is the first thing we consider pretty much with anything, unless it's surgery is the only clear answer. Definitely helps. And a lot of people say, why is therapy going to help? It's not addressing arthritis, but actually, you don't just think the bone and cartilage, it's muscle and tendon, and building up the strength around your knee and actually even your hip and core can tremendously take away some of the pain you're feeling. Helps with going up and down stairs, helps for seeking just activity. So there are plenty of patients, whether it's arthritis, degenerative meniscus tears, or inflammation of the kneecap, therapy is the tried and true way where the vast majority never need to do anything else other than either formal physical therapy or even just a home-directed program.
Okay, Dr. Zacchilli, what are the best exercises to help alleviate arthritis pain in the knee?
Yeah, the most important thing with any of our therapy in the knee that I like to focus on is we're trying to achieve stability. So the reason our knee hurts, whether it's meniscus tear, cartilage injury, ligaments, it's always about a lack of stability very frequently, or the way that the surfaces rub against each other. And so the stronger our muscles are to stabilize the knee, the less those things tend to hurt. So the best sorts of exercises to control stability are ones that apply to both the muscles in the front and in the back of the leg. So swimming, actually, Dr. Schell, is one of the best exercises. It's generally speaking very low stress on the knee, but it activates your hamstrings and your quadriceps. It encourages full range of motion. So those are the sorts of activities that we really love to decrease knee pain. I also like exercises where your where your feet are planted. We call those closed chain exercises. Those, again, tend to activate both the muscles in the front and the back of the knee, optimize stability, are less likely to bother you.
Okay, Dr. Schell, can you talk a little bit about remedies other than surgery for an arthritic knee?
Yeah, so again, physical therapy, home exercise program is probably the mainstay, but obviously anti-inflammatory medications. And there's a whole dozen list. And I always tell patients, Advil, Aleve is fine. We have ones that are a little more longer lasting. Sometimes one will help you, whereas one doesn't. So every body is different. So, you may have to go through until you find the one that alleviates your symptoms more than, say, your neighbor. We do talk injections, cortisone injections for arthritis or just inflammation. Cortisone is a very strong anti-inflammatory. I tell patients, look, it's running through our body right now. We're just taking a focal dose, but it doesn't go through the whole body. It's just staying into the knee, but it's very effective at calming down pain. Doesn't last forever, but it can last months and months and months, and it can kind of go back and forth. Sometimes it's good, sometimes not. The analogy I tell patients is like going to Vegas and playing craps, where basically when we give a shot, we roll the die, but it is better than the house. It tends to win. If that doesn't help, particularly with arthritis, there are other shots called viscosupplementation or hyaluronic acid. It's a cushioning shot. It is not putting in new cartilage. It's putting the fluid that you have in your knee, like a Dr. Scholl's gel pad, for lack of term, and we're trying to pad the knee. These are things that are temporary, but on the order of months to try and get you back less aware of your knee. And then if it progresses, there are other options that we can talk. There's turmeric, cherry juice. These are things that actually you can take to help as an anti-inflammatory calm down your pain.
Okay, Dr. Schell, in the chat box, someone asked, what's your opinion of Voltaren?
So Voltaren comes really in two forms. Voltaren is diclofenac is the generic name. It's a very good anti-inflammatory. But again, sometimes you could take diclofenac Voltaren and feel very good, whereas you could take Aleve and feel better. But it also comes in a cream form, which I think is actually very effective. It is over the counter. It used to be prescription only, but now it is something you can get over the counter. it's like a Bengay type thing, but it's a little more effective, and my patients tend to like it because it is more of an anti-inflammatory component as a superficial. It's not going to cure everything you're having pain, but if we're trying to take multiple things to calm it down, be it therapy, home exercises, gel, shots, anti-inflammatories, all those things together tend to help.
Okay, Dr. Zacchilli, can you talk a little bit about how effective platelet-rich plasma injections are?
Sure. Yeah, that's an area of lots of interest for us. I think a couple important points. PRP is not currently a fully approved or fully researched product yet. We're still evaluating it. We have plenty of research that shows that it helps for pain and knee arthritis. And a lot of recent good research shows that it's equally effective as steroids or hyaluronic acid, but lasts longer. And one really great study out of Chicago shows that if we combine hyaluronic acid and PRP together, we might even be able to get 12 months out of that combination. There are a couple important points. PRP it's a medication made out of your blood. Your blood, my blood is different. Your blood is different every minute. So every time we give this injection, it's a little bit different. That leads to some inconsistencies. The second, that's one of the reasons why the research hasn't supported as a cure-all. The really most important point with it is I think it's sold by a lot of people as this regenerative medicine that's going to regrow your cartilage. And if anybody's telling you that, they're selling you up a river. The point of this is to act as an anti-inflammatory. It is a natural anti-inflammatory made out of your blood, the chemicals in your body, but it's just an anti-inflammatory. It's not regrowing anything.
So, Dr. Zacchilli, let's talk a little bit about prevention. How do you prevent knee injuries from occurring? A patient is a runner, and they were asking us, how do they protect their knees on long runs?
Sure. So I think the most important thing is, first off, to stay active. Most of our injuries come from people who have been inactive or not active enough. So staying active in general. We have some really good research that in healthy knees, moderate amounts of running, so and some research 10 to 17 miles a week, actually was the only thing that we've really shown that can actually grow cartilage thickness in the body. Extreme levels of running beyond that or below that don't lead to growth, but moderate amounts of running actually increase cartilage thickness. So we have nothing else that can do that. Along the same lines, weight control and weight management, keeping your weight healthy is extremely important. The more weight you have, the more weight your knees are going to feel, and your knees feel about 4 to 7 times your body weight. So if you put on 5 pounds, that's between 20 to 35 pounds for your knees. So if you do those things, stay active, keep your weight under control, you're really those are probably the two most important ones.
Okay, Dr. Schell, what does it mean when your knee clicks? And do you need to be evaluated if there's no pain?
So clicking, I have several patients who come in, like my knee clicks, but it doesn't limit me. I just make sure it's not something bad. Most clicking, if it's not painful, tends not to be a major issue. I often tell patients, look, I don't know if you can hear that, but I can click my wrist and my shoulder. I'm not worried by it. It's just a soft tissue inflammation. Clicking, however, can be something that could be worse. And with arthritis, we often hear clicking. We also often hear clicking with just an inflammation on the kneecap called patellofemoral pain syndrome, that it's not bone rubbing on bone necessarily. It's more soft tissue inflammation, like clicking or like cracking your knuckles. But it's not necessarily a bad thing, although it can, if it's painful, give us information as to another condition causing that inflammation.
Okay, what about if your knee is buckling? Dr. Zacchilli, why is it occurring?
Right. Yeah. And that can come from several different places, right? So I think Dr. Schell touched on this a little bit earlier, in that sometimes the instability is what we call functional instability. So functional instability is when your muscles kind of give up, usually because of pain, and your knee collapses on you. So that can cause buckling. So anything that causes pain can cause what we call functional instability. But then you have mechanical integrity that causes buckling. And so that's really more when we're dealing with ligament injuries and sometimes meniscus tears. And so, one question I always ask is the buckling happening in and of itself? Like, is that the problem? Or do you have pain and then the knee feels like it gives way? And if it's the second, we want to figure out what the pain is, but I'm less concerned. If the knee is giving out on you without preceding pain, or you have pain after the instability event, then that leads us more towards that this is maybe a more mechanical or anatomic problem that we have to address.
And I agree with Dr. Zacchilli. I'll tell patients a lot with buckling. It can be a pain reflex. And the best way to describe that is, I'm sure we've all stepped on something in a bare foot, whether it's tack or a rock and you pull away so quickly before it stinks into your foot. It's the same analogy. You buckle and you pull away because of pain, but we don't necessarily register it as pain. It can happen so quickly sometimes.
Okay, Dr. Schell, why does my knee hurt more when I walk down the stairs and up?
So this is a classic. Sometimes I'll say bingo in my mind of this is speaks more to kneecap issues. So classically, patellofemoral joint, patella being the kneecap, will track into the groove at the end of the thigh bone, the femur, and can get inflamed. Whether there's some arthritis or not, we tend to put more pressure on our knee going down than up. So a lot of patients will say, well, it hurts more when I'm going uphill. We tend to think that more as a cardiovascular issue rather than going down tends to put a lot more pressure on the knee. And that's a classic thing generally for kneecap issues, although it's not 100%, but that kind of red flags in my mind. Could it be the kneecap?
So if you have pain going up the stairs, you should come see the cardiologist. If you have pain going down the stairs, you see the sports medicine doc.
Exactly.
Perfect. Okay, there's a question in the chat box. How long should an ACL replacement last? Dr. Zacchilli?
Yeah. So hopefully, the goal with the ACL reconstruction is that we've used other tissue for your body to regrow a new ACL. So once it's regrown and incorporated, it should last as long as your other one would have, unless you re-injure it. So a good ACL reconstruction will last you the rest of your life. That doesn't mean you can't hurt it again. If we look at our numbers, the risk of a repeat injury to the same knee is somewhere about 4 to 6%. Your injury, and someone who's active and playing lots of high-risk sports. In contrast, actually, the risk of injuring your other knee is actually higher. It's anywhere from 6 to 8%. So you're actually more likely to injure your other ACL than you are to re-injure the first one.
Okay, last question. If you had one action step to recommend to our viewers to improve their health and start today, what would it be? Dr. Schell, do you want to start?
Yeah, certainly. So, there's a lot of conditions that can obviously affect the knee. But the one thing I will say across all, if there's inflammation or from whatever cause and pain, I always tell patients I want them to try and avoid hyperflexing their knee. Meaning, if your knee is straight, we call that 0. If you're bending back past 90, try to avoid that position. That it tremendously increases the pressure of the knee, but also the kneecap. Yes, you may bend your knee past 90 degrees, but I tell you, if you're sitting here listening to this webinar or sitting at your desk and you are sitting with a bent knee or what we call the crisscross applesauce, it's just increasing pressure on the knee. So if you have any pain and also going forward, you're increasing the risk of developing some arthritis up underneath your kneecap. So the one thing I do, and I'm terrible at it, 30 times a day, I'm straightening my knee because that's my habit, but I know why I'm doing it, trying to sit with a straighter knee.
Okay, Dr. Zacchilli, would you like to answer that question?
Sure. Yeah, I think touched on it earlier. I think staying active is probably the most important rule. A saying that in my training was always motion is lotion. So the more movement, the more active you are. First of all, it keeps Dr. Weinberg happy. And secondarily, it keeps your weight down. And then the last one really is mobility. So I think the difference between a patient who has some of these injuries that we've talked about and is able to tolerate them and someone who can't, a lot of times comes down to just soft tissue management. So someone who has good range of motion and an arthritic knee tends to be much less painful and much less symptomatic than someone who's stiff. So making sure your muscles, tendons are stretched out, that you're warmed up and you're staying mobile really can make a big difference and in terms of how you experience the problems you have on an x-ray, because we don't care so much about the pictures as how you feel.
Got it. So essentially, the more you move, the better you do. Thank you all for joining us for another inspirational and educational episode of Concorde Conversations. A very special thank you to both of you doctors, Dr. Schell and Dr. Zacchilli, for joining us in our conversation. We appreciate their expertise in educating, encouraging, and empowering our community. As part of the Concorde community, we hope you will share in our mission. Please pass along our emails and webinar links to your friends and family. In addition, please like and subscribe to our YouTube channel. We know many of you have additional questions that we weren't able to answer today. So come in and see one of our extraordinary Northwell physicians to talk about your health. We care about your health. We care about you. Thank you so much for joining us today. Have a great day. Bye.
Thank you so much.